This next case is of a recurrent posterior inferior cerebellar artery that was initially coiled and now has recurred. We will focus on treatment of recurrent aneurysms with simple coil technique. This is a 58-year-old female who suffered a ruptured pica aneurysm 3 years prior, and she was treated with coil occlusion. She was doing very well, and on follow-up, she was found to have a significant recurrence. As you can see from both a non-invasive and angiography, she has significant recurrence of the aneurysm at the neck. Given the fact that this was a ruptured aneurysm, such a recurrence cannot be left alone, and it is incumbent upon the operator to treat this recurrence. The first step is to obtain distal vertebral artery access with your guiding catheter. Given the fact that we're just going to be placing coils and not a stent, very distal access is not required. Under high magnification, we'd like to get a view which separates the pica vessel from the neck of the aneurysm. Here we can see, once we have a favorable view, that we bring in the microwire and microcatheter construct into the intracranial vertebral artery and now into the aneurysm. We can be a little more aggressive with the wire and the catheter, as there is a good packing density in the aneurysm already at the dome. Once we bring the microcatheter into the aneurysm, we're going to withdraw the microwire and prepare for coiling. Here we can see that we're bringing the microcatheter into the aneurysm along our microwire. Ideally, we would like to get deep purchase into the aneurysm in order to help the new coils insinuate themselves into the old coil mass. This is ideal to prevent coil herniation of the newly delivered coils. Once the wire is removed, we now bring in our coils. And we begin to deploy new coils within the old coil mass. You can see that the coils are being delivered from the neck of the aneurysm, being pushed into the old coil mass, and slowly begin to take up space in the newly found residual neck. Ideally, the catheter is positioned in such a place where there is good painting or back and forth motion of the microcatheter deploying coils all along their neck recurrence. Angiography here demonstrates new coils placed in the residual neck and persistent patency of the posterior inferior cerebellar artery. Given the fact that the coil packing density in the neck was insufficient, we're going to be bringing in more coils. At this point, it is reasonable to consider finishing coils or very soft coils to prevent herniation, as we're just trying to fill in gaps in the coil mass. Sizing of coils when recoiling aneurysms can be challenging, as these are irregular spaces, and generally three-dimensional coils can have trouble conforming to these spaces. Again, you can see from the last angiogram that there's still some patency of the neck, and given the history of rupture in this aneurysm, and now the recurrence of the neck, we want to be very aggressive at trying to coil this residual neck, but again ensuring patency of the posterior inferior cerebellar artery. At this point, we have nearly occluded the neck, we've kept patency of the vessel, and at this point, we will terminate the procedure.